Good afternoon, everyone. I am welcoming you. If you can type on the chat your name, your organization, and where are you joining us from? If you're a primary care physician, a nurse, so let us know on the chat so you can introduce yourself before we start. Very well. I see that some of you are introducing yourselves. Jose Alvarado, welcome. Yanira, Gisela, Dr. Juan, Roman, welcome, all of you. Thank you so much for joining us today. I would like to then make some announcements. Remember that we have translation services available for you today. It is available when you select on the bottom of your screen on the interpretation bar. You can select if you prefer English or Spanish. And this is the main room. So this is a service that we are integrating for you. And also our colleague Julio, he is assisting us with the technical matters. He included on the chat the instructions for this service. I would like to give you some general guidelines. We invite you to turn on your camera if it is possible for you. We promote an active engagement. We want you to share your experience and to type on the chat anytime during the session. Very quickly, let's review the agenda for today. And we have first introduction and welcome. We also have general guidelines for this project. And this is the interactive telementoring project for health professionals, the ECHO methodology. And we are using on these sessions and we review clinical cases to learn more about new strategies and applicable practices. And we also have the continuous education credits that will be offered with the participation of these workshops. We also have evaluation metrics, a post test, and this time we have two subject matter experts. So we are very excited to have these two experts today for this session. And we are also going to have a pre-test and a post-test the presentation and discussion of clinical case, some recommendations that we will be discussing as a group. So we are all invited to participate in this discussion. We will have then the evaluation and then some announcements and closing. I would like to mention that this project, it is known interactive telementoring for healthcare professionals. We want to approach the needs in healthcare in the communities through retention of professionals in healthcare, including quality services, access to quality services. So in the initiatives, we have the ECHO series, also learning in real cases, and you're submitting these cases in a community of practice where we have networking, we have access to a library of resources, and we have different topics. This service this initiative is developed by the Institute of Public Health of Puerto Rico, and we have the valuable support of the Health Resources and Services Administration, also known as HRSA. So some of the topics that we will be approaching today are mental health, chronic diseases, maternal fetal health, and nutrition, among others. A little bit about the ECHO methodology. We have these four principles to apply the technology to make the most of the limited resources. And we say that we all teach and we all learn because you, the expert, you share the best practices among your colleagues based on evidence to improve the quality of service to the patients. So this is a learning, as we mentioned before, it is based in real cases and the participants discuss and we evaluate the satisfaction metrics to have a a circuit of feedback. And our colleague Sanchez will be talking about how you could submit the clinical cases. So please uh, share with us this valuable information, Francelis. Thank you, Nicole. Uh, could you please include on the screen your, I apologize. No, we cannot see your screen. Yes, we can see it. Yes. On the top, if you see the meeting screen, I think there is a click where you can click meeting. Yes, thank you. Yes, as Nicole very well mentioned, the eco methodology, eh, it is very important for the clinical cases. And on the right hand of this slide, you can see the form. This form is already uploaded in the IECO platform. It is a way that you could uh, fill out all the relevant information so the experts could give you the best recommendations. Also, you could directly add a question, but if it is a question with good background information regarding the person of that case that we want to improve, it would be much better. So on the next slide, you can see the steps to follow. You can directly forward the case to the email address. Obviously, do not include personal identified information for the patient, or you could use the form that it is already uploaded in the platform. Also, you can upload a Word document or a PDF document, and I can receive it directly. These are the two ways that we can receive cases for the time being. Also, you could use these two email addresses that you see on the screen. This is the contact information. And on the chat, Julio included the case form where you can have a direct link to forward and submit the cases. Thank you very much. Thank you, Francelis, for this information. So we encourage you to receive, so we can receive your cases. Remember that, as our colleague mentioned, you shouldn't include any identifiable information. So just general information. So this series also have a continuous education credits. So you may receive these credits. It's important that during the registration, you include your name correctly spelled as you want it to appear on your certificate. So we are offering this for physicians, nutritionists, nurses from the medical sciences campus is going to be offering these continuous education credits. So you need to fill out the pre-test, the post-test, in addition to the registration, and you need to actively participate in the sessions. Some metrics for evaluation are this pre-test and post-test. On each session, we are going to have a survey. And also through the series, we are going to have an evaluation for change in behavior. It's going to be emailed in the first month and then in 3 months and 6 months after finishing the session. And you can do it directly on the IECO platform. Also for quality improvement, and we are integrating this in our sessions, it's going to be on alternate sessions. Then I want to invite my colleague Alexandra so she can briefly talk to us about quality improvement. Please go ahead, Alexandra. Thank you, Nicole. Yes, during this series, we are going to have sessions, but not necessarily sessions of quality improvement, but we're going to be integrating the evaluation of applicable practices and tools that you may use in the real world. We're going to evaluate that through the pre-test and post-test. So the experts on the series are going to send us some tools that they could offer during the session, and you're going to see on the pre-test and post-test an additional question. In addition to that, practically, that's the summary. If you join us in previous series. Maybe you remember this dynamic. This time it's going to be a little bit different, but we appreciate that you're joining us again. Thank you so much. Thank you, Alexandra. Then, very quickly, so we can start today's session. You're going to have the pre-test available in the polls session. So very soon it will be available, the pre-test, and also it should be available on the screen, and also you can fill it out on the chat. So these are 3 questions. I am going to give you some time so you can answer these 3 questions for the pre-test. Okay, then it's going to be this pretest is going to be available. And now we will continue with our first subject matter expert. I am very pleased to introduce Dr. Yiselly Vázquez Guzmán. So, Yiselly, please go ahead and start with our first educational session. Please go ahead. Thank you, Nicole, and thank you to the team for this space. Thank you to all the people who are joining us today. And my role in this educational session is as an introduction, because we know that the main subject is the nutrition component, and my expertise is in education in health, is in gerontology and communication. So we're going to be talking about how we can approach the older patients. We need to see who are these people and what considerations should we keep in mind when working with them. So Nicole is supporting me with the presentation, with the technical issues. So what's our path today? Well, in the next few minutes, I am going to give you a brief description of who are the older adults, to see that this is not an homogeneous group. There is diversity. And even though there are some characteristics that are present during old age, it is important to consider these particular traits of each person. We're going to talk about aging within our context, because obviously the decisions have a lot of weight in healthcare and in nutrition, but there is a context that take us to make those decisions. We're going to be talking about ageism. For me, it's always a mission in my life to talk about this discrimination that is already internalized many times in our interaction with older adults. And finally, to make a transition to that conversation with uh, to have this clinical approach, and to see those risks that could affect older adults' health. Who is an older adult? According to Law 121, the rights and public policy of the government of Puerto Rico in the benefit of older adults, in addition to the World Health Organization, everyone who is 60 years or older, they are considered an older adult. Before, we were talking about 65 years old, but now we are internationally incorporating the definition starting on 60 years old. So it's important, and we need to highlight that the old age is not homogeneous. Each person has particularities because of their context, their conditions in life, and this really affects and have an impact in what are their health outcomes, their lifestyle, among others. And if we think, and you are in clinical scenarios as a physician, as a nutrition professional, as a nurse, any other role within healthcare services, we can see, and even in our day-to-day life, we could see two people who are 75 years old in the same gender, and they may have a similar life, and we can identify that their health, their functionality, and everything related to nutrition, they are very different, because each person has dimensions that we may see on this slide that affect their performance, their life, their day-to-day. So if we think about chronological age, we need to think about since the day that person was born up to today, we can see how old is the person, including uh, years, months, days. But if, on the other hand, if we see the biological age, we need to see the physical state of organs and systems. There are people who have a biological performance better than others, even though they may have the same age. So this may be due to health conditions, lifestyle, the activities that they do day to day, what they have done in previous years, but also where that person lives or works. And finally, we also need to think about functionality, and that's the capacity that the person may have to perform their day-to-day activities. Cook, have a shower, eat, go up and down stairs, manage their finances, do grocery shopping. All of this we need to take a look into when we think about old age, and we cannot simply fix on the number or that chronological age. So my call in this initial part of this session is to start looking at people not as a category that they are older adults, but seeing those particular characteristics that each person have according to these dimensions. Next one, please. Going back to that concept of heterogeneity, not all people age the same well. If we think about our own context, the needs that we may have and the interests are diverse, they are differ, and it's important to avoid generalizations, saying all people are the same or all people all adults behave one way or the other because there is, yes, a physical deterioration, which is normal, but it is not the same for everyone. Not all people live in the same places or had the same life experiences. Their capacities are diverse. And most importantly, as we mentioned before, their needs and interests are different because sometimes we forget that need or in particular that the person may have to make a change. And if they are not interested at any stage of our lives, we're going to accomplish a change if we're not interested. And it's the same in old age. So we always need to consider the person's interest with every approach, especially in a clinical scenario, because we know, and you very well know since you are in clinical scenarios, that there is a societal desire that the person assumes what the physician or the nutrition want to hear, but we know that the clinical results show something different. So it's important to listen to those needs and those interests. Here, this is an overview, a general overview, and this is data from the Department of Health. These are recent data, and around 31% of the population in Puerto Rico are 60 years or older. This is a high number of people who are older adults, so we need to prepare ourselves for this. And this is my particular opinion. The problem is not that we have an aging population, it's that we are not necessarily prepared as a system to address these needs of older adults. And if we see these characteristics, we can see that around 56% are women, 63% don't have a partner because they are divorced or they are a widow or a widower or separated or they never married. So this really changes the context of what we used to think who were the older adults who were married in a stage in their lives. On the other hand, we can see that around 37% did not graduate from high school, did not graduate from high school. That means that more than 60% of older adults in Puerto Rico have at least some high school education. So that idea, we need to change that idea of this concept that we thought that maybe people didn't know how to read or write. It's important to continue recognizing those needs and making that evaluation, but it's valuable to recognize that diversity. 87% were not employed, and that means that we still have people who are still active in the workforce. And this data is really important because more than half report an income lower than $20,000 a year. So we need to think how can an older adult can live with all their needs uh, fulfilled with an approximately income of around $1,200 a month. It's important to keep this in mind when we're talking about healthcare, malnutrition, and saying that someone is not feeding themselves properly, if they are not receiving the nutrients that they need from what they eat, and maybe this is based on some decisions, but within those decisions, there is an undeniable context that we need to consider. So my call in this first part of the session is to consider those risk factors in older adults that we need to think about the change in what they like, in the smell, they lose that feeling of thirst, and that also affects, we have oral health problems. Most people lose most of their teeth and they do not receive the treatment to replace their teeth, so this really affects them. And also the polypharmacy, the diversity of medications and side effects that this may cause, including gastrointestinal side effects that makes the people to uh, start eating or not eating certain food. Being isolated also has an impact. Some people may have some depression traits. Also, the food uh, insecurity that we see in Puerto Rico. But if we think about poverty, also thinking about the income, there are some factors that's part of what affects nutrition, and also the hospitalization component, especially when we have these post-hospitalization recommendations about what to eat, what not to eat, and how a person could follow the recommendation, because we can share the knowledge with them, and maybe they have the skills to do it, but they don't have the attitude to do it, or they don't have the skills, or who may support them when preparing their meals. So it's important to have and keep this in mind. Next one, please. Also, I would like to keep in mind that uh, ageism, or that discrimination by age, are those stereotypes, prejudices, and actions that make us treat people different because of their age. And it is normalizing that a person may be too old to do this or that it is normal that they may have health problems. We have been very successful as a society increasing life expectancy, but we have not been successful in terms of increasing the healthy life expectancy. So there we have challenges in that care that we provide, and that deterioration, even though there are some matters that are normal, it is not the same for everyone, and it is worthwhile to identify the causes for these symptoms or these alert signals that people are showing in aging. And we need to it we sometimes hear it's normal for them to eat this way because it, or maybe we think that they don't have much to live, or all people are the same. So we need to have a clear perspective to think about the reasons in those changes in appetite, those problems that they may have in their oral health, and that affect all the processes in if chewing, swallowing. We cannot normalize this retardation without having an assessment. We need to adapt the communication to the people so there is some understanding, and we need to include the patient in all the decisions. Sometimes people maybe go with someone who is accompanying them, and the professionals talk to the person who is accompanying them, and this really limits that the person uh, welcomes these recommendations and feel parts of the process. So we want the person to feel part of the process and to welcome these recommendations. So next one, it is important to use an affirmative language. We need to refer to the person or they are not grandma, grandpa, or old man. We need to avoid those. We need to call them by their name. They don't go back to being a child, even though they have some needs of dependency or attention. There is an experience of life that cannot be erased. So we need to ask about habits, preferences, context. Sometimes this history is as important as the result. Maybe a grandma or a grandpa who is taking care of their grandchildren, they are purchasing their food with the SNAP, and sometimes at the end of the month they can only eat rice or spam. We need to take into consideration that context, their autonomy, the patient, they have their preferences, they have their values. So we need to get them involved in the plan so they can be more successful, and we cannot normalize the deterioration. If there is, they are losing weight, if they stop eating, if we see that there is loss of muscular mass, those are alert signs that we there could be reduced. Some of them may be part of getting old, but we need to identify why this is happening.
Leave you with this reflection. Let's go to the next one, please. Why is it important to assess nutritional risk? Because a risk that is not assessed takes us to an untreated condition that gives a deterioration that is not treated, increases mortality, or a condition that affects the functionality of the person, of the elderly. So if we identify these nutritional risks and we take care of the elderly without the bias, with an inclusive perspective, we will be able to be more successful in the type of care that we the care of the conditions. So I will leave you with a question, which is the next slide. Obviously, this does not apply to people who work with nutrition, because I'm sure that if you ask them, I mean, if you ask your patients, when was the last time, what do you eat? So this is a question for the rest of the public. When was the last time that you asked a patient, an elderly patient, what he ate, to describe in his everyday life what they eat for breakfast, lunch, and dinner, they're for snacks. And this can generate a conversation that can be very interesting, that can explain to us a lot of the clinical results that we get. So, my call to you is that we consider these aspects of growing old as part of our health interventions, be them uh, clinical or educational, so that we can be more successful in that role. So, I will be around listening to the presentation of the doctor, and we will come back to talk with you a little bit further. So thank you for the space. Write down your questions, and I will be very happy to answer them later on. Thank you for the people who are in the chat that are answering that I don't remember when the last time was. So you have homework. So all the people around have homework for their next exchange, a clinical exchange. Excellent, Giselle. And thank you very much for your presentation. Now I will move on to our nutritionist and dietist, Valery Rivera Hidalgo, who will give us our second didactic moment of the day. So I will turn over to her so that she can present. Good afternoon, everybody. My name is Valery Rivera Hiraldo. I'm very happy because there are many colleagues here, and it's something that we'll be able to share within this professional community. Um, if you give me access so that I can make my presentation, it tells me that the host needs to give me that permission. Thank you. There we go. Let me know if you can see it. Confirm, please. Okay, thank you. So basically, the doctor started with the, today's topic, and I also have some statistics, but I will move forward in order to focus more on nutrition. Objectives for today are to talk about, from a macro level, how to identify that risk, how to diagnose a patient who is having, oh goodness, who is suffering from malnutrition or self-harm, which we will talk about in a bit. What things or what recommendations, well, general recommendations can be given to a patient And above all, when is it important to refer them to a professional in mental health or to refer them in the area of nutrition, which is the focus of this presentation? Malnutrition has two implications. We're going to talk about malnutrition and also about undernourishment. We're going to, because malnutrition talks about when a patient can be obese and still be malnourished. But we can also have undernourishment because of the lack of being able to eat or losing weight. 75% of patients have undernourishment that is not diagnosed. And this is important. Why? Because we are the professionals that have that first line of defense so that we can identify that in our patient population. Because this increases 2 to 3 times comorbidity and death. And we do not want these patients that when they have to go to the emergency room to be hospitalized, that their death risk increases. In the same manner, 30 to 60% of the hospitalized that are older than 60 years of age are either undernourished or in risk of being so. So these are statistics that are talking to us about the importance of nutrition within the clinical context of our patients above 60. Okay, so in Puerto Rico, the doctor mentioned some statistics about our population. Additionally, I want to mention something that raised the red flag, which is the social isolation. In Puerto Rico, 48% of the elderly have their children are outside of Puerto Rico. So we have a lot of our patients who don't have their kids or their offspring nearby, so they can't be monitoring them, or those visits, that we make to our parents, where we visually go and check on how they're doing and see when they're deteriorating and raise a red flag. So that's very important to keep in mind within the context of what is the type of patient that we have sitting in front of us. Okay, so we spoke about a bit the context related to what we see in our patients. So now let's talk about how to identify the risk. I put a couple of these tools, just two. They're used in community and in hospitals. I know that there are many doctors who not only have their offices, but they also visit hospitals. But these are tools that are answered with simple questions, and it takes about 35 minutes. But the first question that we always propose, so that we force them into the topic. I mean, this even the nurses can do. Not only the doctors, we're all here, the first line of defense to see whether we have a risk of malnutrition or undernourishment. So, have you lost weight without trying to in the last 6 months? It's not because the patient is exercising more than usual or he is making changes in the way he eats or in his diet or using the famous GLP-1s. No, it's if a patient is not trying, is not looking to lose weight and lost weight, 5 to 10% of his weight in the last 6 months, just with that question, we can capture about 50% of the cases of risk patients in just 1 minute. So this can be a conversation that can be very simple, very colloquial, that we have with our patients when they arrive, where we take their vital signs and their blood pressure and so on, and we weigh them. A simple question: hey, do you feel that you've lost weight lately? Or have you been eating well, or do you feel that you're eating a bit less? And those are questions that already leads us into the MNA, which is malnutrition assessment. I put this here in this manner, but I understand that this will be available in the library, or correct me if I'm wrong, so that you can download these and have them as a guide within the initial screening that you do on your patients. So we have the MNA and these 5 steps. The MOS, I don't have it here. There's a link that many doctors use, MedCal. or it's online, the medical application. So there, according to the BMI, the weight, and if they have any type of acute illness at the moment, it gives you a score of the risk of the patient for malnutrition. And within that score, from the first point, you can refer the patient to a nutritionist, be it because they're in the hospital so that they can have a consult, or in the community of offices that you can then refer them to a nutritionist so that she can see them. The M&A were the questions that I gave you as an example when we're talking to our patients. If the patient has lost weight, significant loss of weight in the last 6 months, if they've lost their appetite, this is very important. I just don't feel like eating. These are the expressions that patients will make that will give us a red light. Mobility, are they having difficulty, or they take a little bit longer to move from one point to the next? If they're having dementia diagnosis or Alzheimer, that's also part of the questions that we can ask. And the BMI, their body mass index. Okay, once we identify that the patient is at risk, then we want to know the criteria, what they say, the clean criteria, which are the phenotypical and etiological criteria that are used to diagnose. One thing is to identify the risk, and another thing is to diagnose it. With a diagnosis, which is a GLIM, it's a tool that we use with a consensus, an international consensus. And the most important thing here is that there are things that we can see without having any labs made. We're looking at them and we can identify, besides the physical risks, the physical features, and we can tell whether they're suffering malnutrition. So it's the BMI, loss of weight. I'm going to make a footnote here. The body mass index has its debate insofar as whether this number is a specific criteria to use in people in the elderly population because of the precision and the consideration, because it's the height, the weight, and it's the importance of what's there, which is the muscle mass. Because within the BMI, we don't consider the BMI, the muscular mass. And that's another criteria that is used to diagnose malnutrition. Relating to etiological ones, the food ingest, which is less than 50% of what's required, the nutritionist does, and reduced absorption because the patient already had an acute event, for example, a bariatric surgery, or inflammation, which are chronic illnesses, and most of our patients have something like this: diabetes, COPD, and these are some of the conditions that create this inflammation state. Sarcopenia, which is spoken about a lot, it's an illness. There is an ICD-10. There is a musculoskeletal illness, which it says that there's a progressive loss of muscle mass, strength, and performance. We put here some of the measurements that are looked at for these three areas, but we also have a questionnaire. I'm going to move forward and then I'm going to move back. This questionnaire is called the SARC/F, asks some questions to monitor or identify whether the patient is having some kind of problem in strength, needs assistance to walk, getting up from the chair, walking upstairs, and the frequency of falls. Why is this important to be asked? Because even if a patient looks delicate, no, the other way around, if a patient might look like they've got good weight and a good BMI, higher than 25, 24, it's like, hey, they're in a good, healthy weight. Well, he's not free from having sarcopenia. How do we diagnose it? Well, with this type of question. If the patient can carry something that's 10 pounds, maybe, which is a gallon of water. If the patient can carry things that are a bit heavier? Or does he prefer to be sitting down? Can he carry a grandchild while walking, or does he want to sit down? Has he fallen? These are questions we can monitor and see if the patient has been having problems with his strength. And what recommendations do we have for them? In the same way as when they have fragility or sarcopenia, we recommend strength exercises 2 to 3 times a week, optimization of protein consumption from 1 to 1.5. That's more for the dietitians that calculate this type of diet, and more or less that within every time they eat, they have 20 to 25 grams of protein, not just in one meal, but throughout the whole day. And the supplements of vitamin D. Anorexia. This is very frequent also. The doctor mentioned it. It comes through different factors. They can be physiological. We can see the reasons here. Psychosocial, depression, isolation, social isolation, poverty, their grief. Maybe they lost their animal who was their companion. Medications. Doctors for diagnosis, dysphagia, GERD, pain, dementia, cancer, and the loss of teeth. These are some of the causes that can make the patient say, maybe I'm not eating enough, I'm eating less. These are some of the reasons that we can sort of find out about. What can we say? Maybe you should eat a little bit less, but more times a week. So small meals, but more frequently, so that you can comply with that caloric intake. To revise and simplify the polypharmacy, very important, then the reconciliation of medication of the first primary medical. Oral supplements, it's to add them, not substitute them. This is very important, that the patient doesn't think that with this, that an Ensure or Glucerna eliminates the meal. No, no, no. It's to add to it, to potentiate flavors and flavors. If the patient likes to harvest cilantro or things like that, things that add flavor to foods. That way, you can promote that they include them in what they cook. To eat with someone, not alone. Many times, these patients live alone, but you even in the shopping centers, many people go to the food court, and it becomes a socializing space for them to see other people, and to keep your eye on stimulants like straw, because they have a thrombosis risk. Integrated care. I have two roles here, the doctors and the nutritionist roles, and they're not exempt. It doesn't exempt the rest of the professionals from checking on the malnutrition risk. From the doctor, he detects and refers. He detects that the patient is in malnutrition risk and refers them to a nutritionist. What will the nutritionist do? Create an individualized plan according to what they like, preferences, accessibility, or what is availability, and economics. Educate the patient and their family members that maybe prepares their food, and have that conversation so that the patient can have a better better food habits that comply with the nutritional needs. And the follow-up that we do can be monthly, weekly, according to what the professional thinks. Here, I'm talking about all health professionals. General nutritional recommendations. I always like to use this one. There are many other guides like the inverse pyramid, but for the patients, it's a lot more visual, the plate one. What's important? That depending on the accessibility, the availability, and what the patient likes, we need to promote the ingestion of vegetables and fruit, carbohydrates, things like, the roots, which are a lot easier to chew, and proteins. And if they cannot buy them from animal protein, we can promote protein consumption from vegetable sources. Water, hydration in our patients is extremely important. We have a lot of dehydrated patients, especially now that we have heat and lack of water. So you need to keep your eye on it. The doctors can prescribe, and the nurses can keep their eye on them. Limit the consumption of sugars and salt and alcohol and things like ham and things like that. So when they're losing weight, and what we can tell our patients, if your pants are too big and if you see that the patient is adjusting their belt a little bit tighter, well, we know then that the patient is losing weight. In summary, the routine screening of MNA, which is what we still started with in the elderly, they can from 60 on, is the door to understand whether we have malnutrition in these patients. The, the loss of more than 5% of the weight in 6 months requires a formal diagnosis and labs to identify whether other areas are being altered. Sarcopenia and fragility are reversible conditions with nutrition and force exercise or strength exercise. It's not for them to go and sign up in a gym or something like that. No, we know that many patients don't have the wherewithal to be able to pay that. But I tell them, look for YouTube videos that maybe you can do 10, 15 minutes where you go integrating strength exercises with your body. The anorexia in the elderly is multifactorial. It's not just something that has to do with what they of their desire to eat or their hunger, but we have other components that we can all attack, and that the primary doctor is the first and most important detector. Why? Because nutrition is part of the treatment for every patient. It's part of the medical treatment. These are the references. Thank you for your attention. And this is something that we can use. Everybody can do. Vegetables and fruit, proteins, share with others. That's a very important component. And don't forget to do some strength exercise. Thank you. Thank you, Valery, for all that advice for the health and the care of our patients. I will now pass to present what would be the post-test so that we can take advantage of our resources and have some questions. So if you wrote down some questions that you have for Valery or Yiselly, you can now put them up, and you should be able to see the post-test. And I will have the slides. I will go to the slides so that you can see the QR code. We're seeing a lot of answers. Thank you very much.
Perfect. It's going to be open, the post-test. So if any of you has a question or a concern or a comment, you may raise your hand or you can type your question on the chat box. And now we have time before we continue with our case studies. So let me check very quickly what we have on the chat. They are asking for the bibliography. If we can share that information by email. And here we have a question from Carmen Valcarcel, and she's asking what happens with the hospitalized patients or institutionalized patients. I don't know if Carmen would like to open her microphone and ask the question right now. If not, then I will continue with another question. The primary care physicians can do the nutritional assessments. I think that Valery can answer that. Yes, these two questionnaires, yes, and there was a question regarding if there are any other healthcare professional that can do it. Yes, because what we are identifying is risk. We are not making a diagnosis. So the important thing is what we're going to do when we identify that risk. What are we going to do with that patient that you identify that is at risk of malnourishment? So that is what to do. Well, it is referring them to the primary care physician. You can write to them, send a letter with the patient regarding what you identified. The same with the primary care physician to the nutritionist. They can let them know what is concerning, why they are referring the patient, because that communication among professionals is so important. Yes, because the important thing is that we identify the patient and what we do with that patient initially is to identify that risk. What is causing this patient to be at risk and how we can guide them. Because many times it may be because they are depressed. So then we need to address that with the primary care physician and a psychologist, a social worker, many other factors. But nutrition is always that component. I always said that the food, we when with food we transmit all the emotions. When we feel sad, when we feel happy, we eat more or less, and we select different uh, food. So the referral to the nutritionist is always key. But in addition, we can get involved other healthcare professionals that we understand that may address this risk in their nutrition. Thank you. We have another question from Janine Rivera. In case of patients with hypothyroidism, can they eat soya as a source of protein? And that is work individually with each patient. We know that our older adult patients, they have several conditions, not only we address one of them. So it's important here also the amount of soy. Great. So Carmen Valcárcel, she would like to ask a question. It's how can we work with patients in the nursing homes? The positive thing about the nursing home is it's a controlled environment. You have control of the food that you're offering them. And it is supposed each nursing home they should have a standardized menu, and based on that menu, they can offer always to the patients to eat first the vegetable and the protein, and if they are getting full, they make sure that they already uh, took most of the nutritional density in the first bites and leave carbohydrates for later. And they can also adjust the consistency. If they have difficulty swallowing or they are missing some teeth and they cannot chew very well, you can adjust that. And additionally, if there is already a routine that the participants in that center they eat at the same time, that's a way that they can eat together with other people, at least those who live in a community, and that really increases the intake. And also using supplementation to supplement the meals. That's also important. And among the extracurricular activities that the participants could get could be dynamics that from their seats they can walk sitting down. So we don't want to risk having a broken bone, but to have them as much active as possible within their capacity. Yes, I would like to add something to what Valery mentioned, and it's the importance of training and that capacity building of the personnel in these places, because all these recommendations are excellent, but it is important that people who are working, and mainly those who are taking care of them day to day, the caretakers, people who are managing patients, to receive this information so they can put into practice these recommendations. That's really necessary. Certainly. And at this point, the older adults is not making decision, it's a caretaker. And here we have another question. Thank you to both of you for answering these questions. It is a comment from Juan Raman. He says, to be able to detect depression in our patients, we can ask questions based on the questionnaire PHQ-9 to detect changes in their moods. Correct. But there are a lot of questionnaires, and this is a very broad topic. So we didn't even discuss the physical signs of a patient when they are showing that malnutrition, that we can see them. And so yes, that questionnaire is a tool that could be used to refer to the mental health professional. Great. And Jacqueline Torres mentions as a comment that as a coordinator of Alzheimer's patients and other dementias, uh, they can provide information about symptoms and make recommendations about these questionnaires to other providers. Yes, it is important to identify and what's the action plan. What are we going to do with these patients? So it is not normalized, as I mentioned, that this is normal. And just because it is an older person or a person with a dementia diagnosis. So it's always important to evaluate that risk to identify the causes because sometimes it could be addressed and it's not just because it's a person who is 70 or 80 years old. Then Juan also mentions resistance exercises using elastic bands, and they promote the BDNP in our patients and they decrease sarcopenia. Correct, yes. And the tools that we have available, but we have more accessible. The important thing is that we know that sedentarism promotes sarcopenia. That's what we want to prevent. Uh, 60, 65-year-old patients, and many of them are functional, and they can start. And when the doctor was talking, I was thinking that sometimes we underestimate the capacity of our patients, and we should never underestimate what they can do. We make recommendations, but they are the ones who are making the decisions, and they could empower themselves in the process. Those are the patients. We give them tools and recommendations, but we should never think that resistance exercise are for young people because that's what we see on social media. But no, they are for everyone. That's the recommendation for everyone. So yes, please recommend that to your patients. That's really important. Thank you very much to both of you. I think these are excellent recommendations. Maybe recommending watching videos on YouTube for the patients, or maybe they can join an activity that they may have in their community. In Puerto Rico, I think that there are many events from the healthcare insurance companies in the shopping centers. So maybe to promote things that are already available and they are free, they don't require uh, money. With the resources that they have available, they could be beneficial. So as Dr. Alvin is saying, to decrease the risk of falls, because if they are exercising, we're using those bands with strength training, that could also help with your reaction and your reflex. Correct. Yes, for the patients. Yes, I would like to add something else that I forgot. Please go ahead. If within the patients, we need to evaluate them individually. We need to see their capacity in terms of finances, time, everything. In the ideal world, everyone should be able to have a personal trainer and have a specific plan for them according to their needs. But the reality is different. There are municipal programs that they are promoting physical activity in older adults. It doesn't have to be at 6 o'clock in the evening. Some are during the day or maybe later. So it's important to identify and we can pay attention and tell the patient, well, this is available. And so they may consider it, but this is a recommendation that we should always offer to them. Thank you very much. Thank you all of you for your participating. And now we will continue with the clinical case. So to continue the discussion, I am going to let Valery present to us again this case study. This case study, we have it here. We can see it already. Thank you. Perfect. Yes, I am going to read it very quickly. There's not a lot of information, but just to give you an idea, we may have a great discussion. This is a patient. His name is LRR. He's 78 years old. As a diagnosis, he has type 2 diabetes, hypertension. He has an ischemic ACV. A year ago, in the last 6 months, uh, he lost 8 kilograms. Before he was weighing 70 kilograms and now he's 62 kilograms. It is a decrease in 11.4% decrease. He has no appetite. He lives by himself. He gets tired walking from his bedroom to the bathroom, and his BMI is 21.3. On prescriptions, he's taking metformin twice a day, lisinopril, aspirin, atorvastatin, omeprazole, sertraline. And in terms of labs, we have FBS 198, HbA1c 9.2, and vitamin D 14. I don't know if you would like to type about the findings and the recommendations, what you see in these patients. You don't have to answer the questions directly, but you can type on the chat or use the microphone. Here, Chelsea and Norma, she's saying that vitamin D is low. And a user is saying that the glucose is too high when fasting, and also the A1C. Jose Alvarado says to uh, do the SARC-F. Vilma is commenting that the priority would be to evaluate the therapy for diabetes and to decrease A1C. And Lopez Firpo says significant weight loss. You can also open your microphones if you have any questions regarding this case. You can do it to clarify any questions. And here they're saying that we need to make a referral for a nutritional evaluation. Yes, I also see that one was going to comment. Yes, good afternoon. Good afternoon, everyone. In terms of this case, it is very interesting that we can see that A1C is very high. And this is a patient that is also showing changes in their mood. So we may also see that aspect from a point of view of psychiatry using the PHQ-9 tools to be able to see the stage, what kind of depression our patient is showing. It may be a minor depression, a major depression, for example. Regarding endocrinology, A1C definitely an endocrinologist should evaluate this patient, and this patient could benefit with modern therapy that we are using, like the GLP-1. And we could use a GLP-1, but obviously this patient should be very structured and seen by a nutritionist because the nutritional care are so important. This is a patient that gets tired when walking very short distances. And we need to think about their cardiovascular health. We need to have an EKG, a lipid panel to see how is that cholesterol doing. We need to help the patient from a cardiovascular point of view. Vitamin D is low, and the levels should be over 30 milligrams. So also we need to support that patient from that point of view, maybe with sunlight exposure 10 to 15, 20 minutes, or with vitamin D supplements. And this is a patient that requires multiple physicians actively evaluating to help him. And that will be all on my end. Doctor, I have a question. Let's see. I have a question. What are we going to do with the issue that he's living by himself? Because we could adjust medication, but the patient is living by himself and he had an ACV a year ago. And maybe we could evaluate if they have a dysphagia problem. What do you think? Definitely. Definitely. I agree with you. There should be an evaluation from a point of view to see if the patient, if they have difficulty swallowing, if they are already taking omeprazole. So we may think that maybe that GERD, maybe it could affect the esophagus, and the patient may be having some dysphagia problems. So here we also need to evaluate maybe the involvement of the Department of Health to see why the patient is by himself, to support the patient, that social support that the patient is needing, to be able to complement him and to help him to move forward. I agree. Thank you. I like it. You discussed all the areas. You covered everything. I don't know if Dr. Yiselly would like to add anything else or someone else. Yes, I was reading and I was seeing the comments on the chat, and I think it's very interesting, all the clinical approach, which is so important, but also in terms of, in a broader aspect, what we were mentioning, that he's living by himself, that he's getting tired. It may be related to an uncontrolled diabetes, but also it may be characteristics of possible depression. And when we take a look at medications, we see multiple medications, and possibly this is a link to uh, a chain of symptoms and side effects, because usually when someone is taking omeprazole, it is a red flag, because possibly they are not eating well, maybe some medication is having a side effect in their digestive system, in their stomach, and then they recommend omeprazole. So we need to talk more in terms of this. And it happens with the side effects of metformin. There are many people who say that they are taking it, but actually they are not taking it because they have stomach ache, they have diarrhea, they some people say that it changes the taste in their mouth. So these questions regarding the context are always going to be important. I am not a clinical professional and I recognize that, but it's always important to take a look at this context. And as Dr. Roman was mentioning, it is really important. And as I just saw on the chat, the social component is so important. Those social determinants are so important. This person is by himself. Maybe we need to identify mechanisms of support. Now, some of healthcare insurance coverage are support services to cover social determinants, including prepared meals. And that could be a recommendation to also to identify the context where they live, to see the resources, referrals of the municipal centers, centers from the Department of Families. I always recommend the professionals who see elderly patients to have a directory of resources, and with any person they may share that directory, so they may have services for caretakers, the rights with their healthcare insurance to call the office of the elderly advocates, Department of Families, and nonprofit organizations in the area. It's always important to have that list of resources because the social support is fundamental to manage all this framework. And evidently, there is a clinical decompensation. I am going to add something. Everything that you have said is great. On the comments, they wrote the use of omeprazole and metformin, that it decreases the absorption of B12. And that's really important in the evaluation of the lab work that we may order for the patients every 3 months, 6 months, a year, to include, in addition to vitamin D, also B12. If they are using this medication because this is a chain. They have a diminished B12 and they decrease their hemoglobin. They are showing more sleepiness. This patient is already showing that uh, fatigue, that they are getting tired. Also, there is another medication here, the sertraline, the Zoloft. It is an antidepressant. An antidepressant, it's a red flag for that anorexia that we were discussing previously. What we can say about this patient that yes, that he's at risk of malnourishment. And what can we do? What we have already discussed to refer, to validate medications, to evaluate that environment. That's what we can do in those 15 minutes in the consult with the physician. Refer to identify what other professionals to reconcile those medications, to evaluate that social component that the doctor already mentioned, and to see in what way we could integrate the family. So basically, we discuss the case study. Thank you for all your comments. I am very happy. Thank you. Thank you so much to all the participants. Thank you, Dr. Juan Morales, for your input, which is so valuable. This is a community of practice, so every time that you want to talk, just turn on your microphone. Thank you to everyone who is participating in the chat. And this is the idea, to create that community of practice. So we are going to see on the screen our survey. You're going to see it very shortly. This is a survey. You can see it on Pulse, or you can see the link on the chat, and also on the bottom there in the bar you can see it. And there are some questions we really appreciate because we evaluate the resources that we have on the sessions, the content, the length. These are all important components for us to continue offering this quality service for all our audience in we really appreciate your participation. I am going to share more information that we have a digital library with record resources, and this is for you. There you can find presentations. We have more than 700 resources available for you, 18 topics, 11 formats. So you can use this if you would like to look for information on any topic that we have discussed in the past. You can do it. And here in recursos.prpht.org. And I would like to announce information about our next session. We're going to have them every 2 weeks. This was a recommendation from the clinicians who are joining these sessions, and they are part of a advising committee, and they give us valuable recommendations. And the resources are going to be Kayla Ortiz. She's a nutritionist, and Leticia Hernandez, who is an endocrinologist. And this is going to be nutrition in diabetes and obesity. We are going to be meeting on alternate Wednesdays. This will be July 8th from 3 to 4:30. So I hope that you can share this with your colleagues. And if you would like to submit a case, you can do it, as we mentioned at the beginning of this session. So also, I would like to tell you that there is an opportunity for clinicians from Puerto Rico to participate in a session that originally was going to be for Texas and Colorado, and it's about the use and prescription of opioids and pain management. This is going to take place between 12 and 1:30 in Puerto Rico time, and it is going to be in English. There is not going to be a translation available, but I think it's going to be very beneficial for all of you. And it is also going to have continuous education credits. And this session is for pharmaceuticals, nurse practitioners, clinical assistants. So you should have received, some of you, the link to register online. I don't know if my colleagues could share it that link on the chat. If not, I am going to do it very soon as we finish this presentation. I want to thank you. And if Valery or Yiselly, if you have some final words, I am going to give you some time now. Thank you so much. Yes, I want to thank again the team for this opportunity, those who participated. Thank you for joining us, for paying attention, for giving your recommendations and being part of this community. And my call is always the same. From this non-clinical component of healthcare delivery services, it is important to take into consideration the social aspect, the educational aspect, which is so important. So the person could adhere to their treatment, to their recommendations, and so that they can implement everything that we have recommended that definitely is going to improve their health conditions. So we need to have special safe spaces for our patients that they feel comfortable telling us the truth and not telling us what they think we want to hear. It doesn't matter their age. I know that we have limited time in our consults, but we always need to make space. We need to make referrals, and as much as possible, we need to have public health educators promoting that work. So have a wonderful evening. Enjoy all the sessions in this series. I don't have anything else to add. Thank you so much. Thank you also. Thanks to the Institute for this opportunity. And we hope that we could be good resources for our patients and for everyone around us. We never stop being healthcare professionals. So the best of success for all of you. Thank you to all of you. And we will see each other on the next session. So take care and stay healthy.